decided to do this because I love to help women to be mothers. I'm a woman, and for me it's very grateful to be able to help them. Okay, nowadays we know a lot about the impact of different variables in the cycle outcome, and this allows us to choose the best protocol for each patient. So individualizing is important and it's needed because each patient is different. So we have to adapt the treatment according to the needs of each individual patient. It's not the same to treat a patient of 30 years than a patient of 43 because the quality of the years is not going to be the same. For example, this is one example. So we have to evaluate the patient before deciding which is the best strategy for her. And this is individualization. Yes, well, I think that one of the steps of the whole procedure of the IVF that can be more individualized is the ovarian stimulation. And in this regard, it seems that different biomarkers of the ovarian status of the patient can give us information about how to treat the patient and how to stimulate her ovaries. So in the last years, we have analyzed the value of AMH, that is a hormone that can be measured in the serum of the patient, and it reflects the ovarian reserve of this patient to help us to choose the best protocol of ovarian stimulation for this patient. So this is one of the ways of individualizing the treatment, by evaluating prior to stimulation thanks to the use of image. Yes, I think it's a fashionable topic, and in fact this morning it has been a lecture in which we have addressed the importance of measuring AMH and explaining why AMH is the best tool for predicting the ovarian response of the patient after ovarian stimulation, and also to tailor this stimulation according to its levels. The strength of AMH is that with its value we can predict quite well the number of eggs that the patient is going to produce after an ovarian stimulation. So it's very useful from the clinical point of view, just to inform the patient about the expectations in terms of number of oocytes retrieved. And this is also important to decide future strategies about what to do according to the number of oocytes expected. One interesting finding of the ESHRE study is that when we have compared the AMH levels measured by random up to 3 months prior starting stimulation and starting stimulation day, we have found that they are very highly correlated between each other. And that, what does it mean? This means that I can measure the AMH levels in advance in order to know which strategy will be used in the future for ovarian stimulation. So AMH seems to remain quite stable throughout the months, and this allows us to choose in advance the best treatment for the patient. And it has also been demonstrated that the difference in the AMH levels measured at screening or at the start of stimulation do not impact in the prediction in the number of oocytes. So AMH is a very strong tool to predict the number of oocytes, regardless if you measure it at the starting of the cycle or in the previous months prior to stimulation. Well, I think that we are moving to a personalized medicine. Personalized medicine is the medicine of this century. This consists on looking for different biomarkers that give us information about which is the best strategy for each individual patient. So the objective is to find a tool, and in this case is the AMH, that give us information about which is the right dose and the right gonadotropin for each individual patient. So in the future, we will choose the protocol of stimulation according to this. Until now, there has been some concerns about the reliability of the determination of AMH. This morning I have explained why this variability exists, this biological variability in the AMH levels. But at the end, it's not impacting the prediction in the number of fairs. So we know that although AMH can vary according to the day of the cycle or according to the type of assay used, from the clinical point of view, is not affecting the prediction in the number of oocytes. In any case, I have also explained that the levels of AMH will depend on the type of platform used to analyze it, and that nowadays we have the automated assays that are more reliable. So the recommendation would be to move to this automation in order to have more reliable levels of AMH. I think that for the clinicians it's very important to know that AMH is a powerful tool, because if they think this, they will be using Reproductive, feeling more confident. So with the data that we have now demonstrating that the AMH is stable and is a highly predictive tool, we can say that we can use AMH for dosing Reproductive without any problem. Well, I've been working in IVI Valencia, Spain since 2005, and since then I have treated many patients. I see infertile patients in the office. I also do reproductive surgery, and I'm happy doing this because I have like an holistic point of view of everything. So the most important thing is that I help the patients from the medical and psychological point of view, and it's I'm very lucky because of working in this unit allow us to do not only clinical practice but also a lot of research, and we can investigate on many things, can analyze many of our data, and this allow us to improve and to increase our results. In our clinic, we have introduced many new technologies. For example, vitrification was a landmark in the story of reproduction, the vitrification of the oocytes, because since 2007, when we started doing this, we have increased the number of patients collecting their eggs and cryopreserving the eggs due to social reasons or for medical reasons. So this is one of the most important things that we have introduced in our clinic. For sure, I expect to have an increase in the number of patients, and at the end, the most important thing is just that the patients have to know that you are doing things seriously, and that you are based in science to decide which strategy is the best for each individual patient. many advancements in the IVF field, because imagine that Louise Brown came from a natural cycle, a natural IVF cycle, and nowadays we are stimulating the ovaries just to optimize the outcome of the cycle. So the first thing is ovarian stimulation, the first difference. And we have improved our pregnancy rates thanks to this, and also thanks to the introduction of the ICSI, also the vitrification, the introduction of the pre-implantational genetic diagnostic, because this allows us to transfer healthy embryos into the uterus of the patients. So many things that are helping to improve the pregnancy of the patients. For sure, this is the future. I mean, we have a very strong tool to analyze everything, and artificial intelligence is one of the tools that will give us many information about what to do in different situations. So I think that for sure this is the future. Well, I think that in the next years we will be talking about artificial intelligence, non-invasive PGT, also the gene editing with the CRISPR-Cas, and also we have to focus more on endometrial receptivity, because we have been focused always on the embryo, but the uterus is gaining importance, and there is much to do there in this field.